So, good afternoon, everyone. Today, my topic. Today, I will be speaking about the avascular necrosis of the femur head. So, avascular necrosis, as you know by the name, it is necrosis of the bone due to the vascular supply being decreased. So, once the vascular supply get decreased to any part of the body, it will undergo ischemic changes and eventually death of the cell, leading to necrosis. So this is the femoral head avascular necrosis. So as I told you, ischemic death of the cellular constituents of the bone and the bone marrow. It is avascular necrosis is the ischemic death of the cellular. It is a very common condition, and at autopsy stages, nearly 2/3 of the heads removed show avian changes. So it is very common, but the symptoms are usually uh, pronounced in only a few people. The commonest sites are anterosuperior lateral aspect of the femur and the subchondral area. So 50% of the necrotic heads have a wedge shape, a wedge of viable area at the fovea centralis, which is a blood supply area of the femur head. Mostly we see avian changes in the males, 80% of the cases, and the two in the younger population, in the middle-aged population, 30 to 60 years of age. And it is a bilateral condition, and nearly 34 to 72% of the cases. So the sites of the femur avian changes occur not only in the femur head, it also occurs in the femoral condyles, head of the humerus, capitulum, scaphoid, lunate, and talus. All these bones are prone for avian changes because they have only one blood supply, and that blood supply, if it is damaged, so by many conditions, only one blood supply is there. So if it get damaged, we see avian changes. So the infarcts are usually three-dimensional, and we grade the section into 4 zones. The central zone of cell death, the main part of the blood supply where it is cut, the central zone of cell death, that is the first zone. Surrounding that, there is a zone of ischemic injury, and surrounding that there is a zone of active hyperemia and increased blood supply. And after that, the normal tissue will be there. So there are 4 zones mainly. These are important parts. So what causes the ischemia? Ischemia is caused by interruption of the arterial inflow. So the artery gets damaged, and it causes the arterial inflow disruption. Other is the venous outflow obstruction. It causes the increase in pressure in the area. So it causes ischemic injury. Third cause is intravascular blockade of arterioles and capillaries, which are the smallest part. So the blockade of the arterioles and capillaries is the third cause. And fourth one is the expansion of marrow components. It also causes ischemia by increased pressure. So arterial interruption, main causes are, as I told you, the first cause, arterial inflow interruption. Artery gets damaged in a fracture, a dislocation, in a pediatric condition as slipped capital femoral epiphysis. Infection, also the arteries get damaged. In the frog leg immobilization, for fractures, we apply frog leg immobilization. In that conditions also, we should check the artery pulsations, distal pulsations, after we apply the immobilization. So main conditions are fractures and dislocations, most common conditions. They cause arterial interruption. Next is arteriolar occlusion. Arterioles are very small parts of blood supply, and so the sickle cell disease, as you know, the clumping will occur and when there is hypoxemia. So that is the main cause of arteriolar occlusion. Apart from that, vasculitis, SLE, systemic lupus erythematosus, Haysen's disease, hemostatic disorders, and gout. These are all the conditions for arterial occlusion. So next is capillary compression. Capillaries in Gaucher's disease, which is a glucocerebrosidase disease. Fatty infiltration is another condition. Fatty infiltration occurs in corticosteroids abuse, alcohol abuse, familial hyperlipidemia, and the renal transplant. Next is the hyperbaric conditions. In this condition also, the capillaries will get compressed. Other causes of ischemic changes are hemothrosis, Perthes disease, pregnancy, ionizing radiation, iatrogenic. I'll tell you about in each condition in detail. So, majority of the cases are iatrogenic. So, apart from the fractures, there is a femoral head dislocation, which is the most common cause of femoral head avian changes. So, during femoral head dislocation, there is injury to the ligamentum teres, the main blood supply to the head of the femur. In this dislocation, the superior retinacular arteries may be injured. So once the arterial supply is cut, it will undergo avian changes slowly. And the reduction of the dislocation might return the bone to its normal stress, but there will be a ischemic injury insult, and the rate of recovery depends on the patient and the type of injury dislocation, either posterior or anterior, and uh, with how fast we reduce the dislocation, age of the patient, and all the factors are very important. That's why the dislocation is an emergency procedure and it should be done immediately. And if it occurs in a young fellow, we should check the right, vascularity once it is reduced. So next is a femoral neck fractures. Femoral neck fractures is a very common fracture of the femur. There is a extensive interruption of the blood flow because the fracture uh, tears away all the surrounding blood vessels. So there is a complete blood loss, blood flow interruption. So the sinusoidal vascular bed is interrupted, subsynovial retinacular blood vessels are interrupted. In short, every blood vessel is cut. Only supply to the head will come from the ligamentum teres, as I told you. It's important, but it is not sufficient for the fracture to unite and to cope over the ischemic injury. So next is we immediately reduce valgus reduction helps in increase union, but excess blood loss uh, will decrease the blood supply. So the avian changes in unilateral fracture neck of femur, different studies are done, and in all the studies we can see that once there is a displacement of the fracture neck of femur, the rate of damage or the rate of avian changes is more in all these three, all the displaced fractures. So once it is displaced, the surrounding blood vessels and everything will get damaged. So compared to undisplaced fractures, displaced fractures cause more avian changes. Next is a sickle cell disease. So sickling occurs in hypoxic conditions. So localized areas of epiphyseal and metaphyseal bone areas are prone for infarction. So the epiphyseal and metaphyseal bone areas are very susceptible for infarction. There is a sludging of this sickled RBCs within the sinusoids. That's the main pathology. And so localized and hypoxia, anoxia, or hypoxia will occur because of the sludging of the RBCs, and it will further aggravate the sickling. So it is a vicious cycle. The more sickling, the more avian changes will. So once there is sickling, see this is the damage of the bone. Like this, it gets dead on X-ray findings. This is also damage. I'll tell you about in detail later. So another cause of avian is corticosteroid use. Corticosteroids used for different conditions, for rheumatoid arthritis or collagen diseases. So apart from that, corticosteroids are most commonly prescribed by homeopathic physicians. So whenever we take a history of the avian changes in femur, they usually tell they had a corticosteroid use in the past. So corticosteroid is a very common condition. So what happens is it is not dose or duration dependent. It occurs some people it occurs in a very very minute dose, and in some people it occurs with a short duration of corticosteroid use. So microscopically, there will be fat emboli in the arteries. That is a microscopic feature pathogenesis. So next is increase in marrow fat cell size and interstitial pressure. So the marrow fat cells they get fat deposition due to the steroid abuse, and it will lead to increase in pressure. Again, if the pressure increases, there will be a decrease in blood supply, and again, it's a vicious cycle. Next is alcoholism. It's very frequent among gents and ladies also. So, alcoholism causes alcoholic fatty liver. So, there is a fatty emboli. Fat emboli will go into the systemic circulation, and it will cause the similar to corticosteroid use. We'll see all the changes. Gaucher's disease. Next is next condition where Gaucher's is a deposition of the glucose erythrocyte. It is filled with the histiocytes, and this histiocytes they block the marrow sinusoids, and thus it will block the supply of the oxygen to the cells. So this is the Gaucher's disease. Young child, there's avian changes. On detailed investigation, he had Gaucher's disease. Next condition is a dysbaric disorder. They're related to the pressure changes. Deep sea divers, we usually find it. So it is directly related to the depth of the dive. The more deep you go, the more damage to the bones. And number of dives and uncontrolled decompression and low oxygen saturation. These are all the conditions related to dysbaric disorders. So what happens means there's an accumulation of undissolved nitrogen bubbles in the vascular and interstitial spaces. The nitrogen comes out of the blood and it will not get dissolved. So it will cause physical barrier for oxygen transport. Okay. So this is dysbaric osteonecrosis. See, there is a damage to the femoral head. This is the femoral head, and you'll see the damage. So next is a pregnancy. Usually, last trimester of pregnancy, we can see this pregnancy-related complications. The venous stasis with increased will increase the marrow pressure because of pressure on the venous circulation. Next is a radiation induced. So it is a dose related effect, and it is directly cytotoxic on the marrow or in any cell of the body. Next is collagen vascular disease, the systemic lupus and rheumatoid. In these conditions, we put steroids, a lot of steroids, and it will cause corticosteroid induced vasculitis and damage. Renal transplantation. Here also we put a lot of steroids and immunosuppressive agents, and they cause steroid induced and damage, avian changes. Next is a gout. The sodium urate crystals promote coagulation, and once coagulation, it causes emboli and everything. So next is pancreatitis. Circulating lipases cause fat necrosis, and once there is fat necrosis, it will cause fat-induced ischemic changes. So this is the important cycle. All the Gauchers, tuberculosis, cortisone, and they cause sinusoidal compression. Once there is sinusoidal compression, there is a decreased blood flow. And once there is blood flow, hypoxemia induces arterial occlusion. And due to the decreased blood supply, again there is edema, and again there is sinusoidal compression. So these are all the conditions which cause arterial occlusion, and these are all conditions which cause sinusoidal compression. Once each and everything is interrelated, and this is called a vicious cycle. This is a very important cycle. So next is a pathogenesis of the avian changes. Cuboidal bones and long bone ends constitute they have a honeycomb of cancellous bone packed with myeloid tissue and fat, through which the capillaries and the sinusoids. So once this honeycomb pattern is cancellous bone is packed with the Rogers type of cells or some, they get uh, they 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 interrupt with the oxygen exchange, and thus they cause avian changes. So the dead bone is structurally indistinguishable. It is not able to separate from the live bone initially. After a few days, due to the changes in mechanical pain, changes of mechanical failure repair appear within a week or two. So slowly the changes appear over in the dead bone. Then we'll be able to distinguish. So the bone cells are very susceptible, and they die within 12 to 14 hours, 48 hours of anoxia. So these are the different layers of the bone. So this is the cartilage. You can leave it, and this area is called the necrotic segment. See, and next, this is the area of new bone formation, and this is the normal bone. So X-ray features, we can find a lot of findings. This is the fissuring. Okay, so this is the area of the fissuring, and this is area of breakup. And after that, this is the next stage, whereas the articular surface is destroyed. So the stages of repair. Once there is a ischemic injury, there are 7 or 8 stages, and this is the first stage, phase 1. There is a loss of cell viability. It occurs in first 2 to 4 days, where there is a loss of cell viability. So there's a loss of cell outline, poor straining, and pycnosis, paralysis, everything in phase 1. Phase 2 is an invasion of narrow vascular spaces by capillaries and cells. It occurs in the adjacent live bone, marked proliferation of primitive mesenchymal cells, which help in repair of these. They replace the normal marrow also. And then phase 3, invasion of vascular spaces of dead bone. So within 1 week to 10 days, phase 2, the marrow spaces are of the dead trabeculae. They are invaded by the mesenchymal cells, which remove the debris and everything, and replace with the new bones. Next, stage 4, synthesis of new bone occurs. The new bone mesenchymal cells and dead trabeculae deposit non-woven bone on spongy bone, and over a period of time, fibroblasts deposit the collagen and proteocollagen. Entire femoral head is replaced by 12 weeks. So these 12 weeks are very crucial time. So stage 5, it is a stage of internal remodeling. Osteoclasts come into action and penetrate the non-woven bone and dead bone. They remove removal of the dead bone with the deposition of the lamellar bone. Phase 6 is a very slow internal remodeling stage. It is a very slow process. And after that, phase 7 is resorption of the subchondral bone and inversion of the articular cartilage. Calcified portion of the articular cartilage is there, and rate of resorption of the bone is greater than the formation of the subchondral bone. So there is a more resorption of the bone compared to the formation of the bone. So there is a net loss of bone mass. This is the important point in this page. So the end result is there is a net increase in cancellous bone and decrease in mass of the subchondral bone. So there is a increase in cancellous bone, which is very soft and much useless compared to the main bone. So last stage is the effect on articular cartilage. So the reactive changes in the articular cartilage, it will increase in the thickness of the cartilage, but even though there is an increase in cartilage, it is the underlying bone is not proper, so there is fissuring and everything. So much of the cartilage will get damaged repeatedly. Fibrillation and fissures and complete destruction or loss of the cartilage mass is the final result. And it will all end up in changes of osteoarthritis of the hip joint. So there are different, coming to staging, there are different types of staging. These are all the types of, for UG level, you need Picard and Arlet staging. This, other than all other stages are useful for a postgraduate entrance exams. So I'll tell you about the Picard Arlet staging. So there are 4 stages. In stage 0, usually there are no symptoms and X-ray findings are also normal. Bone scan is controversial. There is no uptake. So this is stage 0. Compared to it is normal. So next is stage 1. There are mild symptoms. X-ray is normal and rest are, there is a mild infarction of the, in the pathology stage. And biopsy will find dead marrow. So usually, even though there is a dead marrow in the bone, there will be no symptoms or mild symptoms will be there. X-ray, we can't find anything. We can find the changes in the MRI. I'll tell you about later. So Picard-Arlet staging is only based on X-ray. Next is stage 2. Stage 2 symptoms are mild. And X-ray, there will be some stages like sclerosing, flattening, osteoporosis, everything will be X-ray findings. And the bone scan also, there is increase in technetium uptake. Next is stage 3. Stage 3, there is a much damage, more amount of dead bone is there, and we'll see a collapse of the head, and the symptoms also, there are moderate symptoms. And if increase in severe symptoms usually comes in stage 5, stage 4, where the joint X-ray also there is a decreased joint space. And I'll show you some examples, then you can understand better. These are all the other classifications. You need not. So next is MRI classification. MRI is very useful nowadays for to detect the early changes of AVN. So even in the stage 1, we can find the MRI changes in the bone density, everything with the help of MRI scan. So the clinical features of AVN. The complaints are usually, the patient is usually asymptomatic in the mild conditions. Once he starts with a complaint of pain in the hip joint, and usually he comes limping to the clinic. And on examination, we find restricted hip movements. And in severe cases, we can find a click in the joint also. So on examination, we can see the restriction of abduction and internal rotation, and due to the shortening of the limb of the joint, decrease in joint space, they will find limb length discrepancy, and other findation, there is a restriction of abduction and internal rotation, but the flexion is usually not affected even in the severe stage also. Final last stage, flexion will be restricted. So diagnosis is mainly by symptoms, clinical signs, and radiological evaluation. So investigations, X-ray is initial test. Usually we find a little bit late the X-ray changes, but MRI we can find changes immediately. The rest of the bone scan, technetium bone scan, and CT scan, intramedullary phlebography, whether we measure the pressure in the bone marrow. They are also useful tests, but they are much outdated. So X-ray is a basic test. They will find osteopenia, There's a decrease in bone mass. In the X-ray, we see a central radiolucency with a sclerotic border. And sometimes we find a subchondral lucency with it is called a crescent sign. There will be a flattening of the head, the collapse of the head in much severe stages. And final stages, osteoarthritic changes, will find joint space narrowing and destruction. So this is the sclerosis. The increase in the bone mass is called sclerosis. See, you can find this area is much sclerotic compared to this area. So this is also the same. And this is the crescent sign. Crescent sign will see osteopenia, also decrease the bone mass. After that, above there is a thin layer of sclerotic area. This is the crescent sign. And you can see the destruction of the joint space. This is the joint. So this is, see, you can see the bone is destructed. So the joint space is decreased. It is called osteoarthritis. And next, there's a desiccation. The femur gets much severely damaged. And this is another form. There's a severe damage. So next is a bone scan, another mode of diagnosis. Bone scan, it is useful in early diagnosis, but it is costly. And where we use technetium 99 sulfur colloid stage, it is useful for early diagnosis. These are the bone scan findings. So another is a CT scan. It also helps in early diagnosis, but the advantage is questionable. MRI, it is a very sensitive method for early diagnosis, as I told you. Well, we see double line appearance on the T2 weighted MRI. Double line appearance because of the junction reactive interface between the ischemic and non-ischemic bone. It is helpful in determination of the exact stage and pathological process. So this is the double layer sign. So next, coming to the treatment, the main goal is to arrest the progression, and to prevent late collapse of the femoral head and the subsequent osteoarthritis changes. So to arrest the progression is the main target. Treatment is planned based on the staging. Before collapse, the structure is maintained. That stage is no effective treatment method have been proven to be effective. So eventually it means that once the disease starts, it will definitely go on towards damage of the femur head. So, but we should not leave the patient. We'll try the conservative methods and non-conservative methods. So non-operative methods are first tried in a hope to halt the progression of the damage. So different types of treatment protocols are there. So once we know the cause, we'll treat the cause. Like if it is a lipid cause, we'll put on lipid lowering drugs, lovastatin and everything. And if the treatment, the cause of the etiological factor is not known, like iatrogenic, then we can try other methods. So apart from general methods are conservative, like bed rest, complete bed rest, traction, and non-weight bearing, in the hope to preserve the joint. Regardless of the weight bearing, 81% of the clinical established avian conditions progress to collapse and secondary osteoarthritis. So 81% of the cases, they will progress to avascular necrosis. So next, non-operative is pretty useless. So operative, these are different types of operative procedures. So initially we try, olden days, we try for core decompression, bone grafting, osteotomy, rhabdo procedure, and resurfacing arthroplasty. But nowadays, total hip replacement has become the gold standard. So I'll first talk about the core decompression. A drill hole is hole is drilled at the base of the greater trochanter, about 12 millimeters thick, and it's passed to the necrotic area. I'll show you the picture. Bone grafting, I'll show you. So, like this, hole is drilled into the femur till the necrotic area, and we can take the bone sample for biopsy also from this part. That is called core decompression. So along with core decompression, we can put a bone grafting, and if we use a vascularized bone graft, it is called precancerous bone graft of quadris femoris Mayer's procedure. It is introduced through the drill hole at neck junction, and the sclerotic area is bone curated, and it is substituted with fibular graft. Precancerous or bone graft with vascular fibular graft. This is called a Judas procedure. We take a 13 centimeters long ipsilateral fibula along with the peroneal artery and vein intact, and the vessel is sutured to the lateral circumflex artery. See, this is the fibular graft. We take the graft along with the vascular structures. We insert it into it, and the artery, peroneal artery, is sutured to the lateral circumfemoral artery. This is called vascular fibular, vascularized bone graft. So it has an advantage of over THR that sometimes it may heal the head more actively, but over a period of time, THR may be necessary. Disadvantages of fibular graft: it is effortful, and we need a vascular surgeon, everything. Post-operative is the same, on weight bearing for 6 weeks, and after that limited weight bearing. Next treatment modality apart from core decompression and fibular grafting is osteotomy. Osteotomies are the aim of osteotomy is to transfer the weight bearing forces from the necrotic area to the healthy area. So if the patient is a young fellow, we can definitely try osteotomy. For fit for young and post-traumatic avian changes with partial head involvement, we can try the osteotomy. Different types of osteotomies are varus osteotomy, valgus osteotomy, displacement osteotomy, and oblique varus, rotational, transtrochanteric, different types of osteotomies are there. So this is a rotational osteotomy where the cuts are made. This is a greater and lesser trochanter. So it is called an intratrochanteric osteotomy, and we cut the bone, the head, and we do a rotation. So this necrotic area is on the weight-bearing surface. Once the osteotomy is made, it is rotated. So the necrotic area will come in the non-weight-bearing area. So it is called a trochanteric transtrophatic osteotomy. But it is useful only in the initial stages. Once the head is collapsed, the osteotomy is very ineffective. And one more effect is there is a limitation of the hip movement because the congruity is not there. So it is not, it limits the movement of the hip joint. Another procedure is a trapdoor procedure where the necrotic area is exactly located, and the cartilage over only the cartilage area, only the necrotic area is open, and the cartilage overlying is open like a door. Necrotic bone is removed, and it is filled with cancerous bone. And again, the suturing is done with, door close is done. It is called trapdoor procedure. So this is the procedure, whereas damage of the necrotic area is there. Avian changes occur over here. The cartilage is removed, the dead bone is removed, and it is filled with the cancerous bone, and the cartilage is closed. This is called a trapdoor procedure for diagrammatic. Next is other type of modality is treatment modality is prosthetic replacement, where we remove the damaged head. It is called hemiarthroplasty. where we remove the damaged head and replace it with the Austrian moves or Thompson prosthesis. These are two types of processes we'll tell you about in the instrument section. And next, hemiarthroplasty, it is done only if the damage is limited to the femur head. But once there is severe damage, there will be damage of the acetabulum cup also. In that conditions, we suggest total hip replacement, where we remove the femur head and acetabulum component. Both are replaced. It is called total hip replacement. So this is regarding the avian of the femur. Okay, then thank you.